Okay, so now we're going to, I guess we can answer some questions if there are questions, and we're also going to do some cases.
If the classifications of coronary are quite extensive, can we still use FFR from CT?
Well, that's debatable. The question is, can we still use FFRCT if there's dense calcium? I think if it's very dense, it's just impossible to see the lumen. Although there's some data that comes from heart flow suggesting you can, I don't think you can. You could use CT perfusion in those cases to analyze the functional significance, but if you can't see the lumen, then I think it's pretty much a guess.
All right, so I'm going to show a case of multimodality imaging, but a case that actually hits very close to what was discussed in this fantastic session. So this is a true case, obviously. A 65-year-old male physician with intermittent precordial chest discomfort for the last 20 days, at times with exertion. But he came and said, something seems wrong. Okay, can you say it louder? So when you have, what is the key word here? It's actually male physician, right? So mea culpa here, right? We don't like to come to doctors. That's probably why we live less than women. But it's a male, exactly. So male physician has a bad sign there. And when he says something seems wrong, you got to take this to the bank. I mean, this is really serious. So medical history of hypertension, dyslipidemia, no prior CAD, normal EKG, lisinopril hydrochlorothiazide, Lipitor, and a coronary CT was requested. All right? We have a coronary CT. I'm just showing the LAD because the CIRC and the RCA, please take my word for it, was fine. But what we see on this LAD here is this eccentric lesion in the proximal segment with moderate stenosis. We did some QCA. We verified the plaque characteristics there, 60 to 70%. But just zooming in here, we have this hypoattenuation. You see this spotty calcification with a darker part here. This is hypoattenuation, as you heard from Dr. Mahmarian. Features there would be considered to be high-risk plaque features, right? All right, so now what should we do? All right, so who votes for A? Increase statin, add aspirin?
Yes.
You do that, right? I mean, that's fine. Why not?
No brainer.
Exactly. Why not? All right, let's go for B. Who would vote for a CT-FFR?
Yes.
Yes, too? Okay. Cardiac cath? Whoa,
Oh.
we got a
Depending on
bunch of
FFR.
hands here. Dr. Barker, you convinced them. All right, letter D here. Exercise stress test.
Option.
Good idea.
All right, so let's move with the sequence, all right? So CT-FFR was not done. We don't have in our center. But let's go. All right, cardiac cath. You voted for that, right? It confirmed. A 60% lesion. All right, I mean, it confirmed. So FFR was not done. Instead, they decided to go with an exercise SPECT, CZT camera with attenuation correction. Okay, let's take a look here. 10 mets, guys.
Right.
It's real good, right? Lipitor increased to 40. Now we got him on aspirin. All right, let's take a look more closely here. So we got the stress on the top, attenuation correction. No symptoms, no EKG findings. All right? Dr. Mahmarian, Dr. Berman?
Yeah, so I mean, that looks pretty good to me. There's a little reduction apically, but it's fixed. And I don't know, I don't have raw data to look at in terms of how much attenuation was present or not, but I presume he had normal wall motion.
Normal wall motion,
Normal
normal
ejection
EF.
fraction when 10 mets, which makes you almost indestructible in itself. So, a lot of low-risk features.
So we've got the inter-observer variability here from nucleus.
Heart rate variability was excellent.
No, inter-observer variability. I think there might be a distal LAD, a distal anterior wall reversible defect, but not, maybe it's apical thinning plus some distal anterior wall reversibility. Might be significant.
Dr. Zoghbi, you got the microphone. What would you do?
MR will be positive.
MR will be positive. No, well, MR will be positive, but not now.
Remember, he had some symptoms before. Did he have any symptoms during the stress test?
No symptoms during the stress. Let's just rewind, guys, because this is a case here that is very humbling. So 20 days, he started with symptoms, sometimes with exertion. He just said, there is something wrong. Check me out. So we did the CT, and that's what we found. He went to the CAF, and he went to the exercise. So 10 meds. I'm not subtracting anything there. I mean, that's the truth. Blood pressure, there was no hypertensive response.
To tell you the truth, you don't have to do anything with this gentleman any further. Because I'm not sure, he has excellent exercise tolerance, EKG is good, no arrhythmia. If there is a mild perfusion defect, what's the big deal?
Exactly.
Right? And I think you've treated him. If he has further symptoms down the line, fine and dandy. What do you think?
So what happened when he came back?
He's come back. That's why you're presenting him.
All right.
3 months, not too
3 months later. Remember, he's a physician, right? So he's delivering a talk. And sudden onset chest pain, small town, large anterior STEMI, prolonged artery balloon time, got to the cath lab with PCR of the LAD, and diagonal with successful results, pleuritic chest pain right after that. Then we got to the CMR, okay? And that unfortunately has evolved into Dressler syndrome. So we had pericardial fusion, large transmural MI, as you can see. There's pericardial fusion, and you can see this late gadolinium enhancement. So not good, right? So that, hits home with the talks that had preceded here, in terms of we should, now that the quality of the images are getting so good and the scanners are getting so good, this is kind of uncharted territory. What should we do when we find these high-risk plaque features? I heard fix them. Should we? Where's the interventional cardiologist? Dr. Barker was here. I don't know if we have data for that, but I think it certainly stratifies these guys into a high risk. Should we have gone to 80 of Lipitor? The plaque, I think, and that begs so many questions. That was shown before. All these features, stenotic significance, the positive remodeling, low attenuation, necrotic core, this napkin ring, spotty calcification, all bad signs, and they add to the stenosis severity. Dr. Zoghbi?
I just want to, obviously, this is a case, all right? And I think, João, you mentioned a very important thing is we really don't know whether intervening on high-risk plaques that are not severely stenotic producing ischemia would ultimately be beneficial to patients. Now, I'm pretty sure we can show many cases similar to this case, right? Who didn't come back with an issue and were stabilized, et cetera, et cetera. So I just want to make sure that we don't come up with a conclusion that we see something that is maybe a borderline lesion, somebody does well, with maybe intermittent chest pain that we have to intervene on all the time. I'm talking about intervention as opposed to intervention with medications. So, but I think it's we know that these are higher risk plaques, and we have to also remember that if somebody has coronary disease, this is a diffuse disease, and 2/3 of the time, an acute myocardial infarction occur not because of the stenotic lesion, but because of the other lesions. So we have to remember those in mind. So you have to decrease risk.
Yeah, just mention that those plaque characteristics can go away with very aggressive medical therapy. So you have a case here.
Dan, is it very aggressive? We're talking big-time aggressive.
Very aggressive.
Yeah. So the exercise test showed that it wasn't a physiologically significant plaque, but it didn't tell us that this was a high-risk ruptured plaque for rupture. And that's the real concern. So that's why I would have been really concerned about that. Now, I'm not saying he needed to have an intervention, but I thought he was at high risk just looking at it.
I couldn't agree with you more. This was similar data. This is actually right hot off the press. This is looking at PROMISE data. Dr. Pam Douglas sub-study looking at these high-risk plaque features. And then as you can see, high-risk plaque features in the presence of significance of stenosis definitely adds. But even when you have high-risk plaque features and no stenosis significance, it might give you a signal, but it's not enough yet. Now, questions here. I don't have the answers for that. This is a rhetorical case more to instill these questions. So he had symptoms, remember that, right? What were his symptoms about when he said there's something wrong? Was that the instability of that plaque? Because we proved that it was not hemodynamically significant.
Could have been, certainly
It- right?
Retrospect, I think, could have been, definitely.
Right, in retrospect, so was this plaque instability that he had associated with his symptoms or not? Do we need to care about the stenosis severity?
Did he get a calf? I'm sorry.
Yeah, you got a calf. And no FFR, but you got the stress test, I mean, if you will. I guess, you know.
That's a physiologic effort.
I don't know. I mean, I'm going to pause for here because, I mean, this
I
was
think there's
just-
one moral. If you're giving a scientific talk, do it in a big city. Isn't that right? Talk in a small city.
That's why we're here, right?
I only come here.
Any other questions?
It just tells you as to where the field is going. Now, the beautiful lectures this morning, it tells you where the field is going, how much we know more. I mean, remember 15 years ago, or even 15 and more years ago, the only thing you thought about is percent stenosis, right? You didn't think about, you know, what does the plaque look like? And the technology didn't even get us there. Now you could take a look with all this beautiful resolution that Dan
Yes.
showed us, that you could look at how hypoattenuated it is. So yes, we start thinking about physiology, but the anatomy looks like will complement the physiology at the same time. So it was really beautiful.
I don't want to monopolize it, but I do want to pick Dan and John's brain. So, of all that plaque morphology, is the fatty plaque, the pre-rupture plaque, more worrisome than positive remodeling? If I had one thing to go on,
I don't think we really know, but I think so. That's the kind of the best indicator of plaque activity. Maybe in the future we'll be adding this perivascular fat density as an indicator of the amount of inflammation that's going on, or even the sodium fluoride imaging that has done with PET that might help us distinguish.
does the positive remodeling tell you about duration? In
Well,
other
it's-
words,
it's
so
the-
that's a longer standing plaque versus a more aggressive plaque?
Don't know. I think.
No, I mean, I don't know necessarily about that, but I think it is true that when you start adding all of these things together, when you have a moderate to severe stenosis, when you have low attenuation plaque, when you have positive remodeling, when you have napkin ring sign, when you have all of these things, it just, you know, the hazard ratios go up tremendously. And so I think, and then if you were to add on top of that FFR, which would probably predict it to be positive based on all of those plaque characteristics, then you could determine a high-risk plaque. Now, where you go from there is a whole different story, right? Because as Dr. Zoghbi was talking about, I mean, Bill, you're right on target. There's no data to show that doing an angioplasty on someone like that is going to prevent death or a heart attack for that matter. So, you know, there's a little bit of disconnect. There are data to show that aggressive statin use may actually be more beneficial than you know, potentially. So getting your LDL down where it needs to be in the 50s, you know.
Yeah, no, absolutely. There's one question from the audience.
Well, I think just to play the devil's advocate, if you had actually put a stent in this individual and you had a complication during the stent, or if he developed in-stent restenosis 3 months down the road, you started him on a new disease process. So I think the path taken with all the thought process is appropriate, because you just, you know, we all want to fix our friends who have moderate lesions because we don't want any of them to come back and tell us, look, I was there, you cathed me, and now I had a heart attack, you said this wouldn't happen. But I think those intermediate lesions are the toughest, but we have the most data available on stress testing and prognosis and physiology. And in order to ignore that and put our belief in plaque characteristics, which we know about, but we don't have long-term data on, is hard in real life.
Yeah. I
Yeah,
couldn't
so
agree with
that's
you.
absolutely true.
Yeah.
I'll just mention in that FFRCT assessment, what's looking like right now is if you take the standard plaque assessment and you give it all the machine learning characteristics, you could predict FFR in the cath lab essentially as well, almost as well as you can with the FFRCT. So we might not have to spend that extra $1,500 in order to get functional assessment from CT.
So, this is a 73-year-old woman who I saw in clinic just about a month or two ago. She had a 6-month history of intermittent, non-radiating, left-sided, exertional chest pain, shortness of breath, and walking 2 to 3 blocks, but it really wasn't reproducible. Sometimes she had it, sometimes she didn't, sometimes she was fine. She had no rest component. Just even recently, she went scuba diving and had no problems going scuba diving. That seemed all fine. Her past medical history, no history of CAD, no diabetes, no smoking, no family history. She did have hypertension, but was extremely well controlled for years, and she had hyperlipidemia, which was also treated, and she was on rosuvastatin 20 and quinapriline, diltiazem, and hydrochlorothiazide for her hypertension. On physical examination, she was completely normal examination. I didn't hear any murmurs or anything, although my ears are going kind of bad lately. I don't know, it's because I get older. Total cholesterol was 203, LDL was 122, so, you know, certainly not terribly high LDL. HDL 51, hemoglobin A1C, just borderline elevated at 6, okay? This is her baseline ECG. Okay, so she had left bundle branch block, and she had normal sinus rhythm. So I guess this is just a question about how would you proceed. Would you go directly to coronary angiography with the intent to revascularize? Would you perform an exercise treadmill test? Would you perform an exercise stress SPECT, a pharmacologic vasodilator SPECT, an exercise echo, or just continue medical therapy, provide reassurance, and tell her symptoms aren't cardiac and have a nice life?
Or a coronary CT angiogram. You didn't mention a coronary CTA.
Or a coronary CTA, that's true. Okay, so if you look at all of these different choices, I think, first of all, you have to recognize that I don't think any of us would necessarily send someone like this directly to the cath lab. And all these other examples are with exercise, and the patient had left bundle branch block, so it really doesn't make sense to do a study in someone with left bundle branch block with treadmill exercise. So she had a myocardial perfusion scan. And this is her perfusion scan. So I don't know what the intra and intra-observer reproducibility of this will be, but, but Dr. Berman, what do you think about this scan?
Looks pretty normal, except for this potential that this is severe LVH.
Yeah, okay, so looks like a pretty normal study, and polar map-wise, she had a 0, and her ejection fraction looked pretty good. So this is, let's see if we can, there we go. I love it when things work, you know, most of the time these things never work for me. Okay, so I mean, I think the EF looks pretty good there too. No regional wall motion abnormalities. And her EF, in fact, was 73% with normal regional wall motion. And so, gee whiz, that's pretty good. So what would you do next? Now would you reassure her, finally, that her symptoms are not due to coronary artery disease? Proceed with invasive coronary angiography to exclude obstructive disease, perform CTA, perform a stress echocardiogram. So, you know, I guess the question is, you know, in terms of reassure that her symptoms are not due to coronary disease, myocardial perfusion imaging doesn't do that because you can have plaque, and if it's not necessarily obstructive, you can still have coronary disease, so that certainly is not the case. You know, I don't know about proceeding with invasive angiography in someone with a completely normal study. I don't think I would do that. Perform CTA, perform stress echo. Well, I don't think another functional test is going to make much of a difference. So, Dr. Berman, what do you think?
Well, I would have said coronary CTA right at the start because it doesn't have these artifacts that can be associated with the myocardial perfusion imaging.
Okay,
It's,
so let's,
it's
so let's see.
interesting.
Let's see what-
Interesting if you had asked the question about 10 years ago, I think you would stop there, right? Don't you think so? Even many places, you would stop there if your stress perfusion test is normal. But we know when you have so much hypertrophy that many things can be brewing, even for a stress echo, right?
Yeah, I know. We could have done a PET on her and looked at microvascular disease. I already showed you those data showing that women higher event rates depending on their flow reserve. So
If you had done the coronary CTA at the first test, you could have completely excluded coronary disease in some patients, or you could have.
all right. Well, that's a good. I like that. So I kind of struggled with that too, except I really thought that her myocardial perfusion scan was going to be abnormal. So I guess it was kind of like one of the reasons I did it. So then I was kind of, but I tell you, talking to her, then I talked to her some more. I said, I really feel uncomfortable about this.
Dr. Berman has a, I mean, if you tell us where are the issues in diagnostic testing, left bundle branch block is an issue for nuclear or echo. And I wonder down the line whether it would be, nowadays I think it is the choice if you're really excluding coronary disease because of the problems with the bundle branch block.
Yeah, but the only thing about the left bundle is that actually with nuclear, left bundle is more of a problem when it's abnormal, the study, not when it's normal.
Yeah, but
Yeah.
It's a guessing game though.
All right. Well, it is somewhat of a guessing game, so this is what I did. Because I said, look, if your CTA is normal, then we're done. And you can go scuba diving again and not worried. But as you can see, she had this chunk of calcium in her left main. That's again, the left main and the LAD, that's the OM2 there, but the circ, you can see this. And she had this in the right, so she had a chunk of calcium at the ostium of the right, and probably a moderate lesion in the mid-right. And so now I had a patient who had a normal nuke, and I tried everywhere. I looked at every single phase on the CT scan. I looked at every single filter probability on the CT scan to try to see if I could get out of that calcium, and I just couldn't do it. So I had to say it's an equivocal CTA. I said, recommend other testing.
It looks pretty darned abnormal, and and we know from years ago that what we call diffuse balance reduction in flow could be missed by nuclear. So isn't this a setup for that?
So that's what I was concerned at. So again, so then how would you proceed now? So again, would you reassure her because both tests indicate low cardiac risk? Continue just rovastatin at a current dose? I don't think so. Now I'm going to blast her down to like an LDL of 50. Irrespective of what anything else shows, prescribe an exercise program to improve cardiac conditioning and her symptoms? Probably not a good idea at this juncture. And or proceed with invasive angiography. So that's what I did. So I didn't do it, but one of my partners, Dr. Barker, he isn't here, but he didn't do it, but he would have been one of the ones who would have done it. So this is their CTA. This is their invasive angiogram. And I just want to show you a shot. I want to show you this shot. So, subtotal left main disease, okay? So that's the right in the circ distribution. This is her right coronary. You can see she does have a lesion in the right here, all right? And if you look at this shot, you can see that there's basically subtotal stenosis of the ostial right coronary artery. So, this is a patient, obviously, who, needs bypass surgery. And I bring up this case because Dr. Berman actually published these data many years ago. I have all Dr. Berman's slides. And I just wanted to comment on this because, here we are with a patient, normal myocardial perfusion scan. Now, if you look at the literature in terms of all comers to the to, this cath nuclear correlations over the year. People with triple vessel disease, probably 1 to 2% will be completely normal, some because they don't have really stenotic lesions, other because of balanced ischemia. This is a patient who, clearly had left main and right coronary artery, completely normal nuke, normal wall motion. So, and the only reason she got extra testing is because I felt uncomfortable. Instead of the patient saying, I'm kind of like on the first case, I felt like, I can't tell you, and I feel uncomfortable. So Dan, what do you think?
What do I think? I think CT should be the initial test in these patients.
But if we had done CT first, I still would have been in a little bit of a quandary based on her because she had rocks everywhere, and whether they are obstructive or not, I wouldn't know. But I probably would have just gone from CTA to cath based on those findings.
Right.
So the only difference would have been whether to do the nuclear first and then go on, or to do CT. But based on her CTA, I think there's no doubt that she would have needed a more demonstrative test.
Bill,
I think based on the CT, you might go to the cath lab on that patient, and then.
John, let me ask Bill something. So, I don't want to sound like a paraphrase of Yogi Berra. You can see a lot by looking. You can learn a lot by listening. So I'm really worried about this woman because she was previously active. She's 73. She's not overweight. She comes in with recent onset of chest pain.
6 months, yeah.
Dyspnea on exertion with very short 2 to 3 blocks. Okay, I mean, that's clinically, if this is a good historian, something bad's happening. This is really bad. So you could almost,
But again, a month earlier she was scuba diving. So
I know, but that's even more worrisome. That's more worrisome. Wouldn't you be worried about that if this woman comes in and says, I'm previously active and now I go 2 to 3 blocks and I'm short of breath and I have chest pain? That's something.
History is important. Clinical history is important, but it tells you that you have different diagnostic tests that you're going to have to navigate one way or another. I mean, there won't be a classic case always for you. And I think that tells you that if you look at perfusion, I'm pretty sure this was imbalance of perfusion, and that's why you didn't see it. And I think the more we realize the limitations of our technique, then you use other techniques to hopefully try to improve your diagnostic accuracy.
Well, in deference to João, you could have picked up this triple vessel disease pattern if you had done a stress MR because it sees the subendocardial region.
Yeah.
And to tell you the truth, if you'd done an exercise echocardiogram, this ventricle would have fallen apart. But you cannot tell a priori. This is all retrospectively, right?
Yeah.
Because this ventricle would have fallen apart, and you'd say, oh, did she get a hypertensive response? Or was she ischemic? Or whatever the situation is.
Okay, I'm going to show you one more really quick one because
Yeah, we got to go.
Huh?
Well, why don't we take some questions, because they have to eat within an hour.
Okay.
Why don't we take some questions, maybe in the next 4 or 5 minutes if there is any, and then we'll tell them what to do. Questions?
Yeah, what was the bottom line of your case? What I was asking, what's the bottom line of your next case if there are no questions?
Okay. Yeah, I can. So this is kind of an interesting guy too. This is a guy I saw preoperative clearance for pancreatic cancer. He was going for a Whipple. All right. So anyway, to make a long story short, this guy actually walked 16 flights upstairs to get to his apartment. Okay. He's very physically active. Everything is, his LDL is 129. ECG really showed nothing except first degree AV block. So the question is, how would you proceed? I would have said, there's no reason. I mean, baseline criteria, the guy is physically active. He has no real reason to have any kind of functional test. So at this time I said, you're older, you're kind of older, and you do have a little bit of hyperlipidemia. So I did a calcium score.
Oh, well, what is that rationale?
Okay, so look at this. So I do a calcium score in the guy, and it turns out that this guy who goes up 16 flights of stairs has a calcium score of 3,203, okay? So I said, now I got myself in hot water because he's going for a Whipple and he's got a calcium score like this. So,
Remember, Dr. Martin is 75.
so now, I said, well, I can't just have a calcium score that high. So I do a nuke on him, and he's got all this inducible ischemia. Yeah. So it turns out he's got like a 25%, 32%, sorry, is almost ischemic perfusion defect. And he has normal wall motion. So that's probably all ischemia. So we go ahead and at this point we said, well, we got to do something. So we went ahead and cathed him. So now we cath him, and you see he's got a tight subtotal diagonal. He's got an occluded right, all right? And he's got also an obtuse, this is the right here. He also has an obtuse marginal over here, which you can barely see. It fills retrograde bicollaterals. So now he's got all of this disease. He's got occlusions. So to make a long story short, Dr. Lowry, one of our surgeons, I sent him the films, and he ended up in the surgical suite getting a quadruple bypass before his Whipple, which incidentally he did very well after his bypass, had his Whipple, did very well, and is now, now has an LDL of 50, so.
Now he has chest pain climbing 16.
No, it's... Yeah, he had a cabbage first, then a Whipple. All set.
I think I would have started smoking, eating French fries, and climbing the stairs.
Well, we want to thank our panelists and our speakers for wonderful, really presentations. Let's give them a